episode of the Sri Lankan Understanding. I'm Shanuki Dialvis and we are here at the beautiful Maitland Stateroom of the Mount Lavinia Hotel, our location sponsor for this program. And I like to explore the Sri Lankan Understanding through the lens of women's histories. What have women contributed in the past? What do they continue to contribute in the present? And how can we make the future female, more female in Sri Lanka? And to have this conversation today, I want to talk about women and medicine. And to do that, I have a very special guest who is also a very special friend, Dr.Rashmira Balasuriya. Thank you for being here. And you might have seen her all over the place because she's become a prominent voice, especially in reproductive health and rights sort of conversations and advocacy for women and health. So I'm very glad you accepted my invitation to be here, considering that you are also a new mom and you have like loads going on. You're everywhere. You're like the Pope, honestly.
Thank you for having me, Shanuki.
Thank you for being here. So, Dr. Rashmira, can I call you Rashmira?
Yeah, Rashmira is fine.
Rashmira. So specifically, like getting into it straight away, women and medicine. Now, I want to talk about two things: women's experience being in the health sector, as doctors and as health practitioners, and then also women's experience with the health sector. So there are two different experiences in Sri Lanka. So let's start with being someone in the sector itself. Can you tell me a little bit about the history of women in medicine when it comes to Sri Lanka? Like, who's made it happen in the past? You know, what are the gaps? How have women been contributing to this role kind of in the sector, in the medical industry? Just give me a answer.
So Shanuki, if you look at the history of women in medicine in Sri Lanka, Sri Lankan, the Ceylon Medical College actually was at that time, they only opened the doors to female medical students in the late 19th century. So around 1892 is when we got our first female medical students. And then we had our first graduate doctor, Dr. Alice de Boer from Ceylon Medical College in 1898. To be exact.
Sri Lanka had the first hospital in the world, right? Historically, it says Sri Lanka, long in the Anuradhapura ages or something like that.
Yes.
So it took that long for women to actually be allowed to be a part of it. Yeah,
and at that point of time, we were under British rule. So I can imagine that not just the societal expectations of what women had to be, which is more of a domestic role, but also looking at the colonizers' ideas, the missionaries' ideas. They wanted women to have more of a domestic role in society. So having a career as a woman was one thing, but having a career as a doctor was a completely like unheard of thing at that point of time. And even then, getting higher education for a woman, getting clinical training for a woman was very challenging. And they actually had gender segregated clinical practices. So even the dissection rooms and things were segregated by gender. So it would have been immensely challenging for women then to learn, you know, from the eminent male doctors at that point as well. So
Wow. And who are some of the pioneering women in the healthcare sector who today or yesterday, like, who have made these entrances and
for all of us
open the doors, so to speak?
So if you go all the way back, like I said, Dr. Alice de Boer was the first female doctor, and she actually led Lady Havelock Hospital, which is now Lady Ridgeway Hospital. And she trained a lot of female doctors and female surgeons under her, so again, like paving the path for them. But another doctor that people might have not heard of as much, but I think has really inspired me, is Dr. Mary Ratnam. Have you heard of her?
Yes.
So she wasn't Sri Lankan born per se, but she married a Sri Lankan. She's Canadian, and she lived and worked in Sri Lanka, and she was a huge advocate for family planning and reproductive justice. And despite a lot of opposition at that point of time, she opened the first family planning clinic in Sri Lanka during World War II. Almost. So I mean, really inspirational there. And then of course today we have a lot of really inspirational female doctors who are paving the way for all of us juniors. For instance, we have the first and the only female consultant orthopedic surgeon, Dr. Melanie Amalsurya. She still is the only one in a field of more than 100 male consultant orthopedic surgeons. And we also have Professor Neelika Malavige, who needs no introduction. I think most of Sri Lanka knows her after the pandemic. Her work in dengue research is world renowned. And even when it comes to COVID, I think the reason we moved through COVID pandemic quite well was because of her and her research in testing and the strains and vaccines and things like that. So there are a lot of women who have really been trailblazers and really put their foot in the door for and opened it for other women as well.
And thank you for saying there are a lot of women. Of course, when you kind of go into like a consultation app or whatever and you're looking for doctors, there are a dime a dozen women doctors. But there is a gender bias in this country when it comes to seeking professional healthcare services or within the sector itself. So can you talk to me a little bit about, post-colonial times, we are in modern times, there is gender equity that we keep talking about, but what is it actually like in the medical field, in medical school? Are there gender biases?
Yeah, so I mean, I feel like so much of, in any kind of career there is gender biases, but in medicine, in Sri Lanka, in the profession, there's a lot of gender bias as well, right? So if we take it all the way back to Dr. Alice DeBoer and her time, then when women graduated from medical school, they were primarily put into either maternity care or missionary hospitals at that point of time. And then after independence came, there was the expansion of free education, they recruited more doctors to medical school, and then the numbers slowly increased, right? Today, I'm very proud to say that in Sri Lanka, for instance, the number of female medical students is significantly increasing. It's now more than 50% of the cohort is female medical students. And there was a recent paper published as well, and they are projecting that there's going to be at least 70% of female medical students in the coming years. And in taking the number of female specialists we have more now than we've ever had before. So that's a really positive thing. But of course, that hasn't come without its challenges, without its barriers, right? Working in still a very male-dominated field is quite challenging for women, especially when it comes to leadership role. There's a lot of disparity there. So in their senior academic roles, senior administrative roles, women are often overlooked for these positions. And even when you're choosing a postgraduate specialty, for instance, there's a subtle steering of women towards specialties like pediatrics, anesthesiology, family medicine, and even though I'm in family medicine, there's a subtle steering of women towards those roles, and there's a subtle pushing of men towards more surgical specialties, more interventional medicine kind of specialties.
I want to explore that a little more in detail, but we will go into a small break and be back soon to continue this conversation. Welcome back to the conversation, and we're talking about women's histories in medicine. Dr. Rashmira Balasuriya is here to talk about that, and in our previous segment you mentioned now in medical school, in medical college, you have a huge component of women, sort of, that you have said it's now looking like it's almost going to be 70% of medical graduates are going to be women. And yet, it is still a very male-dominated sector. So can you talk to me about this male-dominated? What are the specialty areas and sort of the areas of health where it's still male-dominated, and why, when you have so many women who are passing out and qualified, why are they not choosing to specialize in certain areas, or are they being kept out?
Yeah, so when you think about some of the specialties, I think obstetrics and gynecology was one where a few years ago it was very difficult to find a female OBGYN, and even now trying to refer a patient to female OBGYN is still a bit challenging to find one.
That's funny though, right? Because you'd want to specialize in something that you can relate to, and
yeah, but now actually it's looking like the current registrars and senior registrars who are coming out of postgraduate training, it's almost equal now. So in the near future we will have a lot more female obstetricians and gynecologists coming out, which is very exciting. And I think all of us have had different experiences when it comes to seeing a OBGYN, and having a female OBGYN might give patients a little bit more ease, I would say, with talking about reproductive issues. But there are still certain specialties, Shanuki, that are very male dominant, and you probably know some of them, like orthopedic surgery, urology, cardiothoracic surgery, still very male dominant in Sri Lanka. And that is because there's this perceived notion that it requires a lot of physical strength to do those specialties, and also it takes long hours. So women are deterred a little bit, and they are subtly steered away from it because of the societal kind of expectations and norms where women have to be mothers, women have to be caregivers, they have a domestic role to also uphold. So unfortunately, women don't get that mentorship and that kind of that like help when they want to pursue these specialties as well, because nobody's holding the door open for them a little bit. Do you know what I mean?
Yeah, sure. And then let's talk about the patients also, right? Because we were just talking during the break that, you know, female patients who I would have assumed would be more comfortable, for instance, seeing a gynecologist or an obstetrician who was female, that you have sort of, you can talk to someone who relates to your condition or you feel more comfortable with. Patients themselves would opt for a male doctor instead, because there's kind of like a perception that the male doctor is somehow better at his
more
job.
skilled.
Like, what is that all about? Why do you think that exists?
I mean,
or does it still?
At the moment, I must say in my current practice, I practice family medicine, and when I refer a patient for obstetrician gynecologist kind of opinion, I always ask them, I said, are you okay with seeing a male? Do you prefer a female? What is your kind of idea? And most of them now prefer seeing a female. So I must say my patients have also kind of pivoted that way. But historically, I used to have meet patients who wanted a male doctor because they thought a male doctor was more skilled and had, you know, a better understanding, which always blew my mind. And I think it's kind of upholding the patriarchy in a way also, because you have been kind of, you know, told from your small days that men are doctors, and then you assume that they are the ones who are more skilled.
Yeah.
Yeah.
Okay. So then veering into the patient's experience also, if I can ask you about women's medicine, right? Healthcare for women in particular. Why in 2025 do we still have so many gaps where the medical industry doesn't cater to women as much as it should, and a lot of things are very homogeneous in the way medicine sort of looks at patients and treats patients, but we are not. We're different. Our bodies are different. Can you talk to me about the gaps in women's medicine?
I think there is a global gap, not just in Sri Lanka, but globally there's a huge gap when it comes to women's medicine. Historically, a lot of research that has been done on even medication, Shanuki, has used men as their sample population. So we don't know how certain medication acts on women. Even the work of painkillers, for instance, we don't know if they're as effective on women as they are on men. So we assume that women can just take the same amount of painkillers, the same dosages, the same frequencies, and it will have the same effect, which is wrong. And it's only now that more research is being done into how drugs act on women. You know, we have different hormones, we have different bodies essentially. But even then, Shanuki, I think you and I, we understand that women go through so many different phases in life, right? For instance, from puberty and menstruation to pregnancy to the postpartum period to menopause. We as women go through different stages that require different strategies, different healthcare services, right? Now, in Sri Lanka, when you talk about pregnancy, we have it pretty good actually. In Asia, we have one of the best, you know, healthcare strategies when it comes to covering pregnancy. Our maternal mortality rate is very low. We don't have mothers dying of, you know, childbirth and pregnancy and things like that compared to the rest of Asia. But still, there are little gaps there as well. But now, when you take menstruation and puberty, yes, there's a lot of talk now about menstruation. Doctors are now taking it a bit more serious when you have problems with like pain, irregular periods and things like that, and diagnosing conditions a bit earlier. But still there is an unmet psychosocial need, I feel, for girls going through puberty, right? Because when I used to work in the rural hospitals, I used to work in a district general hospital, which is like a middle kind of a sized hospital. It was very common on a weekly basis that we get a young girl with a paracetamol overdose. And they've taken overdoses for the very small minor inconveniences. They had a fight with their mother, they took paracetamol overdose. So there's an unmet psychosocial need for women and for girls that I think really we need a strategy there to help young girls maneuver puberty, maneuver these emotions that they're feeling, right? Then again, in the postpartum period, we don't have a perinatal psychiatrist in Sri Lanka. That is not a specialty.
Not even a single one?
No. So if you have a mental kind of problem when you are in that postpartum period, you have to go to a general psychiatrist. We have mother-baby hospitals, mother-baby units in government hospitals where the mother can stay with the baby when they're having a psychiatric condition. But we don't have a specialized perinatal psychiatrist in Sri Lanka, right? And that is a huge gap that I feel, because only when you talk to women and they feel comfortable is when they tell you, oh, I went through these kind of feelings, I had anxiety, I felt like harming myself, I felt like harming my baby. But that doesn't come out when they talk to a doctor, because there is that power dynamic. They can't tell a doctor or a healthcare worker this openly. So there has to be a strategy in place for that. There's a significant gap there. And then menopause. We don't have a healthcare strategy for menopause in Sri Lanka. And a lot of women who are reaching the peak of their careers are going through menopause. So they have to deal with the physical symptoms, the psychological symptoms of menopause, and just withstand it. And they don't understand there is help available. We don't even have some of the drugs that we require for hormone replacement therapy in Sri Lanka. We don't have a very comprehensive kind of strategy for women in menopause. So there are serious gaps, not just globally, but especially in Sri Lanka, that I think we can tackle now, especially that they are developing the upcoming healthcare strategy for the next 10 years. So I think it's very important that we add menopause, we add perinatal mental health into those strategies.
Thank you for saying all of that. And we will be back right after this short break to wrap up with a conversation on where are we going with medicine in Sri Lanka when it comes to our women. Welcome back to the conversation on women and medicine in Sri Lanka. So Rashmira, if you can now detail a little bit on the conversation that we started in the last segment, where, you know, what are the gaps in patient treatment? And you did sort of lightly touch on that, but treatment of women when it comes to healthcare, you know, whether it's providing mental health services or whether it's providing, like we talked about, like how women are treated when they come, you know, and is there a difference in the way it happens in rural care or in maternity care, as we talked about, or in mental health services? And you were telling me there are some areas that we really need to work on and improve, right?
Yeah. I think when it comes to rural areas, Shanuki, there are barriers that women especially face in those areas. So things like mobility restrictions, right? Financial barriers. And of course, there's a power dynamic, because most people in the rural areas, there's a huge power dynamic between them and the doctor. So even freely expressing their concerns, and they're scared of being judged, scared of being gaslit basically by the medical professionals. So there's definitely a huge way in which gender plays in that kind of a scenario. But especially maternal health, you know, we have a high institutionalized number of births in Sri Lanka. That means a lot of women give birth in a hospital setting. But then when you think about patient autonomy, patient care, you know, when they're delivering their baby, there's a lot of violations in terms of labor room ethics, right? And there's more research now coming about obstetric violence. So those are things that we really need to improve, and it's again gender specific. Again, with mental health services, women are often told they're being emotional. They're often gaslit for what they're going through. And so then they fear going to see a doctor when it's something regarding their mental health. They would rather suffer in silence. So gender plays a huge role, I would say, in kind of healthcare services and delivery.
So there's a long way to go. And then let's add the layer of cultural and societal norms, right? The expectations. And I mean, women just don't go to the doctor sometimes, even though they absolutely need to, they won't. And because there's I don't know what it is it an ignorance of understanding that there's something wrong with us? Is it the fact that we are shy to talk to doctors or let somebody examine us? And women in the sector itself, in the professions itself, how are cultural and societal norms impacting or influencing them?
I think cultural and societal norms for any woman in Sri Lanka, it's a deep issue, because we all work around these cultural and societal norms, right? But especially for patients, for instance, when they have, because my interest is sexual and reproductive health and I experience in that I'm talking about that, when they have an issue with their reproductive health, they will just stay at home and bear with it, because they're scared of judgment, they're scared of having to speak to a male doctor about something they feel that the male doctor won't understand. So they would rather bleed at home, you know, heavily, have irregular bleeds, and not seek help for it, right? There's that shyness that we don't talk about reproductive health, And even sexual dysfunction, for instance, if we have pain while having sex, that's not something we go talk about openly.
Yeah.
So they will suffer with that in silence at home, and until it becomes a bigger issue, they won't speak to a doctor.
Yeah.
Yeah. For female healthcare workers, society, you know, we are made to work like we don't have children and have children like we don't work. That is kind of the norm that is expected of mothers, right?
Yeah.
Of women in healthcare. So a lot of women face this huge pressure where they have to take care of their children, take care of the domestic, you know, aspect of their lives, but also have a career and have, you know, aspirations at the same time. And it doesn't always go together like that. So a lot of women put their career on hold, or they slow down their career purely so that they can achieve, you know, better balance at home.
What about safety for women in the sector?
Yes, I mean, recently we had a very, you know, a very scary
and
incident.
That can't have been the only thing, the only one that's happened, right?
But then it made all of us, I think, who work in the healthcare sector, Shanuki, reflect on our experience and also on what we put up with. You know, working, because we work 24-hour shifts, 72-hour shifts at a stretch. I have worked like that in the government healthcare sector. We don't have lit corridors. We have to run to blood banks and other areas of the hospital in pitch black with just our phone torches, right? We have one security guard at the entrance of the hospital. We don't have security guards all over the grounds. Our quarters are in another dimly lit area. I mean, when you think about what we put up with and didn't question it at that point of time, it's ridiculous, and it's unfortunate that this incident had to happen for all of us to have a bit of a rude awakening on what we put up with and what we accepted as okay. So there's definitely safety concerns for sure.
And let's hope they're being addressed, because unfortunately and tragically it takes something really, you know, sad to happen for people to suddenly wake up. And I hope it's not just going to be all talk and, you know, that gasp and who and clutch the pearls and say, oh, something needs to change, but then nothing changes because there are. But if I can then ask you this one last question, what do you hope that the future will be for women in medicine and women seeking medical help in Sri Lanka? What do you see as the future?
For a woman seeking medicine, I think we need to change the mindset of doctors and healthcare workers starting from medical school. I think there needs to be gender inclusion, you know, a curriculum on gender intersectionality, because you can't treat patients if you don't understand your patients, right? There also needs to be better healthcare strategies to cover all the phases a woman goes through in life. So not just pregnancy, there's so much more, right? That's another thing that I think female healthcare health patients would definitely benefit from. For healthcare workers, I think there needs to be expanded mentorship programs for women in medicine, especially in those specialities that we don't have enough representation, enough women in. There needs to be expanded mentorship there. We also need flexible workplace policies, right? Because at the end of the day, you can't expect a woman to act like she doesn't have children, to work like she doesn't have children, and to have children like she doesn't have work. So we need definitely more flexible workplace policies to help women achieve their fullest potential in medicine.
Thank you so much for putting that across, and thank you for listening. We have come to the end of the show, but as I always say, we need to keep these conversations going. It can't stop with just one episode on a talk show. But I do hope that if there are people who in policy and in the healthcare sector who are watching this episode, this is a conversation that you will be inspired to sort of keep going and continue, and advocates like Dr. Rashmira will be loud voices at those tables. Thank you for being here with me today, and thank you for listening.